Well, hello everyone. I'm Hye-Jin Clark. I'm a member of the AAPM&R Content Creator Workgroup. I'm a current chief resident at Stanford PM&R and a member of the FIT Board Council. And I'm honored to speak with Dr. David Lee today. And so I'm going to have Dr. David Lee introduce himself.
Yeah, thank you. I appreciate that, Dr. Clark. My name is Dr. David Lee. I'm a PM&R trained interventional spine doctor. I graduated, I got to think about this because it's been a while now. I graduated about 13 years ago now, PM&R at SUNY Downstate in New York. I did an interventional spine fellowship in Arizona. And then currently now practice at the University of California, Irvine here in Southern California. I practice in a small office with two other orthopedic specialists in a satellite office for UC Irvine.
Amazing. And no, Dr. Lee, you are doing incredible things for AAPM&R, and you're actually one of the leaders of the Pain and Spine Advanced Clinical Focus Day. So tell us a little bit about your role in that.
Yeah, thank you. So I actually my kind of experience with AAPM&R kind of goes back a little bit. So I got more involved approximately 6 to 8 years ago when I joined the Clinical Practice Guidelines Committee. And so for those of you who are on the call who kind of have this desire to try to get more involved with the academy, I think it's great, but you kind of need to start somewhere, and so it's kind of like you don't want to go like jumping and diving, headfirst in the shallow end. So I kind of dabbled in the Clinical Practice Guideline Committee, and I was a member on that committee for about 3 years, and then eventually kind of matured into becoming chair of that committee. So I've been chairing the Clinical Practice Guidelines Committee now for 5 years now. And the only reason that I stayed on for a fifth year is because there's a kind of transition in leadership within the academy, and so they wanted me to stay on for an additional year, which I was humbled to do so. In the Clinical Practice Guideline Committee, essentially people are asking, well, that sounds amazing. What do you guys do? So we look at any kind of clinical practice guidelines that are being published or being disseminated in our communities. Anything that's relevant to the physiatry community, we collect and essentially bring to the committee for review. We use a tool that's been vetted, and then we review those clinical practice guideline or CPGs, and then based upon their merit and their rigor of development, and then of course lastly on how they apply to us, if we agree with their recommendations and how the implications for the physiatry community, and then we give our endorsement, or we infirm it, or we can even reject the actual CPG. The reason it's important is if you get an endorsement from the academy, then you can actually utilize the seal when you're disseminating this information to the community and saying that, okay, this is actually like endorsed by the academy, which is pretty strong. That having that kind of rigor of endorsement is only comes with like the most top tier CPGs that are being put out there.
Well, it seems like you do incredible work with them, and you're taking your leadership skill into developing an incredible session for us for
Yeah.
the big PM&R Annual Assembly that's coming in October in Salt Lake City.
Mm-hmm.
So tell us
Yeah.
about the session that you're going to be leading.
Yeah, so I got approached. I will give a little shout out to Dr. Mukul Desai, who was doing this before me, and so I kind of half jokingly, half not, but I had a lot of large shoes to fill from his standpoint. He's a great colleague, and I'd say also a mentor of mine. He's amazing. He's done a phenomenal job with the academy, and on the interventional pain standpoint, he's done a lot bringing education to the annual meeting on a consistent basis. So he kind of has filled his role and kind of started to kind of walk away from that role to do other things, and I was approached, and I was of course very happy to take over where he left off. We have a few sessions going on. Dr. Yang is running a couple of those sessions. I know a lot of the colleagues who are on all three of these different sessions and panels. The one specifically that I'll be moderating focuses on facet joint, spinal stenosis, and SI joint pain. It is a session that's focused on interventions for these conditions. And this particular panel is made up of both seasoned as well as new PM&R pain doctors attendings. And so I think there's going to be a wide spectrum of perspective that's going to be brought to this panel. Even though its focus is on the title is for interventions, and we will be talking about both classic interventions as well as novel treatments for pain of these different types of pain etiologies. We also want to focus on the clinical nuance, the evidence basis for decision making, and also the kind of collaborative care pathways that are involved with this, right? So we want it to be germane not just for interventional spine and pain specialists that are from the PM&R background, but we also want our general physiatrists to find some kind of value from this discussion. I think that the other aspect of this is that there is a kind of a critical point, right? A line where innovation meets restraint. So, we have all these very exciting things that we want to introduce to our fellow PM&R Academy members, but we also want to be smart with implementing them, right? So just because you have a new toy or new widget, new therapy, doesn't necessarily mean that it's going to be applicable for every single pain patient out there. It's critical to diagnostically identify the patient and then to utilize the appropriate therapy for that diagnosis.
And I think your session seems to really encompass the kind of PM&R philosophy of really improving somebody's function and quality of life, and not just sticking a needle in somebody. So that line, just kind of going back, you're doing a lot of spine care now, but you're PM&R doctor first. That was your first primary specialty. So
yeah, absolutely.
PM&R, and how did you develop an interest in spine care?
Yeah, so this came about kind of organically. When I was doing PM&R, we would, of course, see a lot of patients, both outpatient, inpatient, for particularly back pain. But, back pain, sciatic pain, radiculopathy, hip pain, knee pain. And my concern was that, when practicing general physiatry, which is critical, right? You're dealing with a huge spectrum of different types of etiologies, not just pain, but SCI, TBI, so and also MSK issues. But specifically to that of pain issues, when oftentimes we would refer them to physical therapy, ascribe them to a very regimented program, they would come back to us, and then if it didn't work, most of the time, thankfully it did, but if the conservative medical management did not meet their needs, then we would have to then refer them out to a pain specialist. And thankfully, we had a pain doctor within our department, so then I would continue seeing that patient. But my concern was, from when I eventually would leave that academic setting, is if I have to send these patients out to a pain specialist, I would lose that continuity of care, right? Because oftentimes what happens is, and this goes, for other subspecialties as well, you send a patient off to a different subspecialist, never to be seen again, right? And you don't have control of the narrative, you don't have control of what's being done. If the specialist that they're sending to, that's the best, right? But sometimes you don't, and so they're just kind of going off to a different person, and then when they come back to you, then you have to kind of put the pieces together and figure out what was done. Versus if I have the ability to perform certain procedures like medial branch blocks, facet blocks, epidural injections. If I can read MRIs proficiently, I don't have to send them out to somebody else to do that for me.
I love that. You're kind of taking all your passions and, you're getting more tools in your toolkit to help your patients kind of enhance.
Sure. Yeah.
Kind of amplifying that effect, which is amazing to hear. And, you are so involved, not just in AAPM&R, but you're in a lot of the other national pain societies. But what are you looking forward to our annual assembly this upcoming year in Salt Lake City?
Yeah, that's a great question. I want to do and sit in on things that are not spine related, selfishly, because I get exposed to spine stuff all the time. So I think that highlights the beauty of what the Academy meeting offers. Is I go to other meetings, of course, and you mentioned my involvements in different societies, most of which are pain related. But when you go to them and you sit in on different discussions, it's all within the sphere of pain and spine, right? Versus when you go to the general meeting, the refreshing thing for me, and the reason I love going to the annual meeting, is I can go to like an MSK lecture. So one specific topic that I'm going to go kind of selfishly go look for this upcoming year at Salt Lake City is orthobiologics. Last year, I had the opportunity, which was granted to me as being the CPG chair of as being a moderator for one of the panels on orthobiologics for the knee. This was driven from a CPG that was specific to that topic and germane to that topic. But even moderating that panel, I was blown away. Right. I mean, I do get some exposure to different orthobiologics just by nature of my practice and being with the orthos. But there were certain things that we got very granular, and there were certain details and things that I hadn't known about. So I think the field of orthobiologics is really exciting. The idea of some type of regenerative treatments that we as physiatrists can do is great. And in particular, that's so because in general with pain management, most of what we do, like 95%, 96% of what we do, beyond physical therapy is palliative, right? So if we can, turn the tables on that and flip that on its head and have therapies that are actually regenerative that we can do injections for and procedures for, I mean, I think that's the future.
I love that you're not just thinking about the traditional like epidural steroid injections, but you're taking in inspirations from like the PM&R, like sports and sports and MSK world, and kind of bringing that to your practice. So that's awesome to hear. And you kind of mentioned earlier on, you've been in the kind of the field you've been practiced for at least 13 years and beyond. So you have a over a decade of experience in interventional spine and pain medicine, and you play a lot of active roles in national committees. And so what leadership lessons have you learned that are critical for advancing the field? And what advice would you give to early career physiatrists who are looking to lead in this space?
Yeah, sure. So like a two-part question there. So for the first part of that, in terms of my experience in leadership lessons, I think the biggest one is that, and I've seen this particularly in the field of spine. Dr. Clark, you might understand this, kind of with your interests as well. But I think progress in our field is no longer siloed. And what I mean by that is that the future of minimally invasive spine, the future of spine care and pain care in general, I don't think will be determinant on one subspecialty alone. Like already you've seen this, right? So like in my career, like historically anesthesiologists dominated pain, right? That's not the case anymore, right? It's like 50-50 PM&R and anesthesiologists. And now I even have fellows and residents from ER and family practice going into pain as well. So it's definitely diversified, but it goes beyond that even. A lot of technology has allowed us and afforded us to be able to do minimally invasive procedures that traditionally surgeons would do, right? So, but there's also like this kind of turf war, right? So that we learned this when interventional cardiology and interventional radiology first came out. So pain is no different. It's going through its own kind of growth, and growing pains along with that. But I think the end game would be is that if we can collaborate, these decisions of who does what and where the lines are going to be drawn, it's going to have to be a physiatrist, anesthesiologist, a surgeon, other subspecialties in that room making this decision at the same table. In terms of kind of advice for early career physicians, my constant kind of talk track with them is embrace the discomfort. And it sounds terrible because it's like residency and fellowship's hard enough, but really that the discomfort is where the innovation happens, right? So if you oftentimes I do this with myself too, is if I find myself in a space where I'm complacent and super comfortable, that's great, and there's nothing wrong with quality of life, prevention of physician burnout. That's not this kind of conversation. But when I say embrace discomfort, is that sometimes when you're doing things outside your box, like that's where you're really going to grow. And so for early physicians, I think that's the most important part. You have plenty years in your latter parts of your career that you can be nice and comfortable and complacent, right? Like you have tons of time to do that later on down in your career. But like really like the first especially like the first 10 years, now that I'm kind of coming out of that decade, I'm like in the second decade of my career, but really that first 10 years of your career, you really want to be doing, different things, right? And kind of like pushing yourself, beyond, just the regular limits of what you're used to.
No, I love that phrase of, getting comfortable with the uncomfortable, because
Yeah,
that's
yeah,
where growth
100%.
comes. And speaking of getting comfortable with the uncomfortable, we're gonna end with a fun question. And Olympics is a major event where we get
Yeah.
comfortable with the uncomfortable. So if there was an Olympic event for something you do outside of medicine, and that can be a hobby, talent, or hidden skill, what would you be competing in?
Yeah, yeah, that's great. So I love that. I love that question. So I actually do some consulting work and some work with the USA volleyball team. Yeah. So they have a center out here near Anaheim, and I years ago, happenstance, made connections with the team physician there, and then he didn't have as much experience with the spine specifically, so we've collaborated on patients outside of USA Volleyball. But then he started asking me to get more heavily involved, which is great, and that relationship has been very, very different and refreshing from my typical practice. But if there was a USA volleyball event, well, I will say that I've kind of taken up more to pickleball, which I know is very popular now. I know a few colleagues of mine who would love it nothing more than pickleball to be a actual sport in the Olympics. But I just started that, and it's been good because I have history of playing tennis, so that transition hasn't been terrible. I would say overall I play a lot of different sports, but none of which I'm good enough to be actually a competitor, a realistic competitor in Olympics. The one funny thing that I would kind of answer if this is acceptable is that I never talk about it, but one of the passions that I have outside of medicine is I love to do like interior design. And no, it sounds extremely strange. It's not a sport. I doubt that the Olympics would ever make it into a competition, but we purchased a house, in around COVID. Actually, believe it or not, there was a lot of people who were doing like updates to their house. We actually decided to move, which was a crazy experience. Um, but when we did that, we moved to a brand new house, and I had the opportunity to like design like all these different things. And for me, that's always gonna kind of like a passion of mine, right? Like they have all these TV shows where you watch people like design things and inside of their house and matching everything and kind of making it kind of eclectic and highlighting different things in the house. So for me, I mean, if there was a competition for that, sign me up.
Wait,
Hopefully I can get bronze in that.
well, let's go for the gold here. What is your favorite room like that you design? Because there's different rooms. So what's the room that you're
Oh
most
yeah.
proud of?
Well, so anytime people come, it's funny, every time people come to my house, and my wife is so kind about this, but they'll always ask like, oh, like ask my wife like, how did you design this and that? And she'll point to me and just like, oh, that's all David, like he's the guy who's kind of driving that ship. No, it's I think it's different for everybody. Like, you have to, one of the things that I've kind of learned in talking to friends and colleagues in when they're kind of going through their own process is that everybody has their own different style, right? Like my style is completely different than maybe what my wife would want and my sister would want. So finding that kind of right style, and then kind of like being able to look at everything and making sure that they complement each other. It's a skill. It's an absolute skill set.
It's such an art too, and there's like an architecture involved. And that is, well, you're a man of many talents, so that's incredible. And we're so grateful that you took the time to
Yeah.
interview with us and share your enthusiasm for the upcoming annual assembly and all those incredible things you're doing for AAPM&R. So thank you so much for your time, Dr. Lee, and we look forward to seeing you in Salt Lake City.
Yeah, I look forward to seeing everybody in person. Thanks, Dr. Clark.
Thank you so much.